I haven't met Ajad.
Thank you. Nice to meet you, sir.
Right, same here.
Good evening, everybody. A warm welcome to the IBD Masterclass at IBDENC. This August, we have something very interesting, exciting, something as clinicians we need to know. It's the era of biologics, and now small molecules have been launched. Does the landscape change? What happens? What is best for our patients? Today we have leading stalwarts from across the globe. In this discussion, we will go from the theory, the rationale with every decision, and again a case-based discussion on what will be best for our patient. Without wasting time, in fact, getting straight on to the subject, it's my great pleasure and honor to introduce to you a name which is well known to all of you, Professor Charles Burnston. He is the Distinguished Professor of Medicine, Director, University of Manitoba IBD Clinical and Research Center, the Bingham Chair in Gastroenterology at Manitoba. His work encompasses every area of inflammatory bowel disease. He is a leading stalwart and has contributed immensely to the knowledge of IBD in this part of the world as well. He has been actively involved in exploring the biologic and the clinical intersection between different chronic immune mediatory diseases, and I think therefore he's the best person to talk to us on IBD beyond the conventional, the recent advances. Over to you, Professor Charles Burnston.
Thanks very much, Rupa. It's wonderful to be with my friends from India and my good friend Chris Mulder, although it'd be more fun to be in person, but that's not 2021, maybe 2022. Let me see here. Let me end this and let me get to the sharing my screen. Can you folks all see my slides?
Yes.
I think, yes.
Wonderful. Well, the organizers and Rupa have asked me to speak about small molecules in IBD, and while there may be many small molecules in IBD, I know she really wanted me to focus on the JAK inhibitors, and that's what we're going to do this morning in Winnipeg, and this evening in India, and this afternoon in Amsterdam. So Manitoba's in the center of Canada, and right now it's 30 degrees Celsius outside, but in 6 months from now, it's going to be 30 degrees below Celsius, and this is Lake Winnipeg. Manitoba is very, very flat. Europeans who come here always marvel at the space and the flatness, and this is ice fishing on Lake Winnipeg. Now, Lake Winnipeg is the 6th largest lake in North America after the 5 Great Lakes. Now, something else Winnipeg is very known for only in the last few years is the Canadian Museum for Human Rights. It's the only museum outside of Ottawa that's a national museum. And Winnipeg is a very liberal community and has been known for human rights since its inception in 1870. And in fact, the first labor strike in the history of the world was in Winnipeg in 1919. Now, in front of the Museum for Human Rights is a statue of a friend of India. And I'm not sure if Gandhi was as comfortable in his statue when it's the middle of winter. And this is what Gandhi would have looked like had you ever had snow in India. But this is a snowstorm in front of the museum last year. So I'm going to start my discussion with a few questions. And I'm not going to necessarily answer these questions now, but we can come back to them in some discussion. If I'm out in the audience, I'm thinking, I'm concerned about using JAK inhibitors during COVID, especially. I'm concerned about using JAK inhibitors due to viral reactivation. And we're going to talk a little bit about herpes zoster. Do you vaccinate for herpes zoster routinely in your ulcerative colitis patients anyway, even before you're considering a JAK inhibitor? I'm concerned about using JAK inhibitors due to venous thromboembolic disease. We're going to talk a little bit about that. I'm concerned about using JAK inhibitors due to cardiovascular events. You'll see the term MACE, which just stands for major adverse cardiovascular events. And finally, I'm concerned about using JAK inhibitors due to cancer. So we've come to be familiar with certain concerns potentially with thiopurines and with anti-TNF when it comes to skin cancers and lymphoma. The JAK inhibitors bring a different set of issues to think about when we're considering the risk-benefit ratio, and we consider this with every intervention, or we should consider this with every intervention with patients we undertake. And then ultimately, and what makes JAK inhibitors different is, do you think patients with UC who need an advanced therapy would prefer to take a pill, an injectable, or IV? And or do you as a physician are thinking of, well, whatever works, let's get them better? Do you practice in a more paternalistic way of choosing for them? What we find in our clinic in Winnipeg is that people really want to be involved in this discussion, and having pills again, much like we always only used in the 90s when we only had thiopurines as an option, people are enthusiastic about taking pills. And then again, does retention affect your choice of advanced therapy? And by retention, we mean the ability to keep a patient on that medicine. And of course, if we give them pills, they have the option and opportunity on their own to simply stop taking them without necessarily us knowing, as opposed to someone who's coming into an infusion center. These are my financial disclosures, mostly with local Canadian companies, but some international disclosures. Okay, so let's talk about Tophascitnib first. It's a pill. It's administered twice daily, and it is a JAK1 and JAK3 inhibitor, which makes it a bit broader across the spectrum of JAK inhibition than some of the newer ones. And if it's broader, it's possible that it may have more toxicity. Now, these are the Octave data published a few years ago, led by Bill Sanborn. You can see that for induction, patients in remission in the top left, that by 8 weeks, there was a delta of about 10 to 13 points, and that was statistically significant. And more importantly, I think then potentially the induction data, the maintenance data, or Octave sustain, looked very good. Whether it was 5 or 10 milligram dosing twice daily, it was 35 to 40% compared to 11%, which is a delta of about 25 to 30 points. And, you know, that's a number needed to treat of 3 to 4, which is very good amongst our new therapy data. You can see for mucosal healing, the Octave induction data also looked very good. At 10 milligrams twice a day, you had mucosal healing in 17 17-point differential, which is a number needed to treat of only 6. In Octave Sustain, the mucosal healing data was also very good. So we're all familiar with the notion that we not only treat people till they feel better, that they're clinically in remission and they're not symptomatic, but we also want their mucosa to heal so that we'll know that they'll stay in remission. Now, this was the extension of that data published by Jean-Fred Colombel last year, the maintenance of remission data. You can see here that in the very light gray panel in the middle bars was 10 milligrams twice a day. Interestingly, over 3 years, it didn't look that different than 5 milligrams twice a day. That was for patients in remission and also for mucosal healing. It really looks quite comparable up to 3 years, making us believe that if we get patients into remission over time, we can drop that dose to 5 milligrams twice a day and maintain that consistent 80 to 95% remission rate or mucosal healing rate, which is really quite excellent. This study, called the riveting study, was taking patients in long-term remission on 10 milligrams twice a day, and then they were randomized to remain on 10 milligrams twice a day or drop to 5 milligrams twice a day. And the data look a little bit different than what I just showed you that Colombel had published from the long-term extension of Octave. So what you see here in blue, the blue bars, I hope it's coming out. The riveting study was taking patients in long-term remission on 10 milligrams twice a day, and then they were randomized to this efficacy endpoints at month 6. In blue, you see that the data were a little bit better for maintaining 10 milligrams twice a day than dropping to 5 milligrams twice a day. And that was true right across the different response ranges. So there was some loss of response in this study. That is, you maintained a better response if you stayed on 10 milligrams twice a day. This was a subgroup that entered into the extension study with a 0 score for the endoscopy, which you can see the differences weren't as great. If patients entered into the extension study with a score of 1, having some granularity, 1 and 0 are quite different on the Mayo score. And you can see that if they start in the randomized phase with a bit of inflammation on endoscopy, they do worse if you drop them to 5 twice a day. If they were people with prior anti-TNF failures, they did a little bit worse by dropping to 5 twice a day than if they stayed on 10 twice a day. So you can see here that there are some subgroup differences. It may make us have to think a little bit harder about when we're dropping to 5 twice a day. But one thing I can say in summarizing, that if you are going to have a patient on 10 milligrams twice a day and drop them to 5 twice a day to try to limit some of the potential side effects, it's best to do it when you know the patient is in a complete remission, if you can. And that includes mucosal healing. If you can get a fecal calprotectin and you can't bring them in for endoscopy, and your fecal calprotectin is less than 250, even better if less than 150, that may be a reasonable proxy. Bruce Sands looked at an interesting data set where
No connection.
We've lost him.
The connection of the actual chart may be dropped.
I'm
Charles,
back.
can you hear us?
Yeah, I can you see me?
Yeah,
Yeah.
we can.
Okay, great. Sorry. There was a weird power surge there and my computer blinked off for a second.
Okay.
So what
Can you
Bruce
share the screen, please, Charles?
Yeah, absolutely. Let me go back to sharing the screen. I apologize, guys. Can you see me again now?
Yep.
Yeah.
Yes.
Okay, great. Let me. So in this study, and the bottom slide is the bottom panel is more important. What the bottom panel shows is that if you've lost response on 5 milligrams twice a day, if you escalate back to 10 twice a day, how robustly do you get people back? Well, not quite as robustly as you might have hoped, because only about 50% or so of people were getting back either on clinical response, mucosal healing, or frank remission. This was a little bit disheartening to see, quite frankly. Now, I want to leave tophascitnib in terms of efficacy and just introduce some of the other JAK inhibitors that are around. Filgotinib is available in MS. It's once daily, which is an advantage. It's only a JAK1 inhibitor. And you can see these data presented by Brian Fagan last year at UEGW, where filgotinib at 200 milligrams per day was clearly the dose that was going to be the one to move forward, both in biologic naive and biologic experienced patients. And in biologic naive, it seemed to do better than biologic experience. We've seen that kind of sentiment before. And this is endoscopic remission, where 200 milligrams is clearly the dose over 100 milligrams, with not quite as robust data as we saw with tophascitnib, but nonetheless statistically significant. In terms of adverse events, remember these are clinical trials, and we don't get to really see all the adverse events within 8 to 10 weeks or even 26 weeks. And if we are starting to see signals of adverse events in short studies, we know that that could be a harbinger of things to come. Now, upadacitinib is another JAK inhibitor, and Chris can probably weigh in if this is available in Europe. Certainly in rheumatoid arthritis, it likely is. And if it's coming to IBD, it is coming to IBD in North America. It is a JAK1 inhibitor as well, and it's used only once or twice daily, but it can be used once daily. So these are some ulcerative colitis data with upadacitinib, and you can see here there are different doses that have been studied. It's interesting that AbbVie chose to study different doses with UPA in ulcerative colitis versus Crohn's disease. And here at 45 milligrams, upadacitinib looked clearly better at week 8, 20% versus 0 in placebo, which is actually the best data we've seen, a number needed to treat of 5 to get people into clinical remission. And for endoscopic improvement, there didn't seem to be a lot to choose from between the doses. There wasn't a big dose response between, say, 15 and 45, which is interesting. The clinical response in people who've previously had 2 biologics, which is not uncommon to start to try these JAK inhibitors when they've been biologic experienced, that data looked very good. People with pancolitis, that data looked very good. And it's hard to see that there's any difference in dose response between 15 and 45. And in terms of safety overview, you're starting to see maybe a bit of a signal that at the higher doses, there's a little bit more action than at lower doses. These are some data in Crohn's disease. Tophascitnib is not available in Crohn's disease. It's only been studied fully in UC and approved in UC, but some of the newer JAK inhibitors are going to be available in Crohn's disease. And again, we see 24 BID, which is 48 milligrams, comparable to 45 milligrams in UC. But what's interesting here for clinical remission, there's this signal that 12 milligrams a day versus 48 milligrams a day was really not different. It's a little bit unusual in the data. In terms of endoscopic response by 50% or a modified clinical remission, you see a little bit of a signal here at 48 milligrams a day, but not that much to choose from between 12 and 48. A little bit of an oddity in terms of dose response here in the Crohn's disease studies with Tophascitnib. Again, here's some adverse effects, and these are small numbers. It's hard to know what to make, if anything, of these. You wouldn't expect to see malignancies. There is no TB of interest, which would be certainly of interest in India. But again, these are week 16. And so, my God, if you saw malignancies within 16 weeks, I don't think this is a drug we'd be talking about. So I want to spend the next few minutes just talking about risks. I want to tell you that in my experience, and I've been using Tophascitnib for a few years now, it can be a very effective drug. But there are challenges, and herpes zoster or shingles is a challenge that is real. About 1 in 20 patients getting Tophascitnib may have a zoster infection present. And what you can see here is that in blue at 10 twice a day versus green at 5 twice a day or placebo, there clearly is an increased risk, and the risk is 6-fold compared to the general population for zoster with Tofa 10 twice a day, much higher than 5 twice a day. And this is the risk for overall opportunistic infections. In these data here, you see some other risk factors that impact, and this is from rheumatoid arthritis data. And you can see that if patients are taking chronic corticosteroids, there's a little bit of an increased risk, a bump in the risk. If they're older, obviously, there's a risk. The older we are, the greater the risk is. And I thought this slide would be of interest to this audience, seeing that there is a suggested increased risk for zoster in Asia versus Western European data. Again, another data set in rheumatoid arthritis showing, in fact, that the greatest risk for zoster was in Japan, Korea, and India, with a 9-fold risk compared to other risks that are closer to 3-fold in the West. So I thought that that would be interesting. And there's obviously more data from rheumatoid arthritis where they've had these drugs available longer than we have in IBD. Now, I put this slide up just because I want to remind everybody in gray, this is healthy adults, and the risk of zoster increases as we age. It is said that maybe by age 85, 1 in 3 of us may get an outbreak of zoster, but you can see here that in patients with rheumatoid arthritis, even if this is irrespective of using Tofa, they are on other immune suppressive drugs, and we've published from our group that IBD patients using biologics do have an increased risk of zoster as well. Now, in this study, just to introduce this, 2 years ago, there was rheumatoid arthritis data suggesting that at 10 milligrams twice a day, after 100 days of use, there is an increased risk of venous thromboembolic disease and even death. And this really put us back because we were enthusiastic about prescribing Tophascitnib, but yet we had to talk to people about the risk for potentially serious clotting disorders. Now, this study was a comparison of Tophascitnib at different doses in methotrexate users to anti-TNFs, mostly adalimumab, but some etanercept users. And this was to compare if there were differences in adverse outcomes between Tofa and anti-TNF. And I think it was a bit of a surprise to all of us to the extent that there were some findings. And here you see in pulmonary emboli, mortality, there's actually a statistically significant difference between Tofa 10 and the anti-TNFs in gray. Tofa 5 really didn't have a significant risk. That's a little bit alarming, and this just came out a year and a half ago. And here you can see the risk for DVT and PE, again, higher at 10 twice a day. 5 twice a day is higher than TNF blockers, but the confidence intervals overlap. The confidence intervals don't overlap here for pulmonary emboli at 10 twice a day. This is major adverse cardiovascular events. What you can see here was that there was a 24% increase in this risk with patients using TOFA compared to an anti-TNF. This isn't TOFA compared to the healthy population. This is people, the healthy population of IBD or the untreated population of IBD. This is to the treated population using anti-TNF. And then with malignancies, and it was mostly lung cancers, there was a significant increased risk of TOFA 10 twice a day versus anti-TNF. So it gives us some pause, and it makes us think about, are these risks real? We need to see more phase 4 or real world data, but it does make us think about who we're going to be prescribing TOFA to. For instance, if we have somebody who is a long-standing smoker, maybe they had COPD and they were at increased risk of lung cancers, since we have a choice of different agents, we may think twice about using TOFA. So to conclude then, JAKs are very convenient and effective agents in both GI and rheumatology, but the risk-benefit ratio has to be considered in all patients. We try to use the 5 BID dose when we can. I will typically give people 10 twice a day for at least 100 days, and then, or roughly 3 to 4 months, and then I will try to switch them to 5 twice a day and see if we can get away with it. Preferably, I'm switching them if I know that they're in a deep remission, that their fecal cal is negative, or their endoscopy looks very good. We should use caution in older patients, not just because they're at risk of Zoster, and we can mitigate against the Zoster risk by using, we can mitigate against the Zoster risk by using vaccines. And we're also, of course, looking forward to more safety data. Prior to starting a JAK inhibitor, it's great if you can get the vaccines done first, particularly to shingles with the Shingrix vaccine here in the West. And in fact, Pfizer's been providing it for people over 50 for free. And of course, if you're going to start a JAK and they're not on a biologic right now, vaccinate them for COVID before you start. It's important to screen for latent TB. That would be very much important in India. Screen for hepatitis, especially hepatitis B. We should not give these drugs to pregnant women. Of course, we should assess their cardiovascular risk. And we should look at their neutrophils and lymphocytes at baseline, their hemoglobin, their liver enzymes, their renal function, and measure their baseline cholesterol. And then if you have a patient on Tophascitnib, after 4 to 8 weeks, you should check their fasting lipids, and every 6 months thereafter, you should check their CBCs. And of course, especially in India, you may need to periodically check them for tuberculosis. There are some next generation JAK inhibitors coming from J&J and Pfizer, more selective JAK inhibitors, anti-TYK2 and JAK1 inhibitors, which is a combination, also from BMS. So I think that we're going to see JAK inhibitors for some time to come. And with that, Dr. Banerjee and the rest of the team, I will end my talk.
Thank you very much, Dr. Charles, for putting into clinical perspective the new generation, the small molecules in IBD. A lot of new information coming in, and I think it becomes even more relevant because it's now available in our country and in this part of the world. So we need to know how best to use them and when not to use them. Now, we will have a discussion later on, and I request Dr. Charles, if it's possible, to stay on for the Q&A session. We will move on to a panel discussion. The panel discussion is themed as positioning biologics and small molecules in the management of moderate and severe IBD. The moderator for this panel discussion is Dr. Ajit Sood. Dr. Ajit Sood is a very senior gastroenterologist with very rich experience in inflammatory bowel disease. He practices in the northern India in a place called Ludhiana, and where he has got vast experience in managing inflammatory bowel disease and also hepatitis C and celiac disease. And he really is an authority in all these problems that he faces or he manages in large numbers. Dr. Ajit Sood, it is over to you to conduct this panel discussion for the next 30 minutes. Over to you, Dr. Ajit. Please introduce your panelists as well.
Thank you, Jian. Thank you, Rupa. We move on to the panel discussion. I'm audible. I'm clear.
Yes.
Yes.
Right.
Maybe you could be a bit more louder. I think
Right. So for today's panel discussion, we have four very eminent panelists. We have Chris Mulder from Netherlands, Najab from Iran, and Devendra Desai from Mumbai, and Matthew Phillip from Kochi. And we'll be, during the discussion with the panelists, if there is any controversy or we fail to reach a conclusion, then the matter will be referred to the third umpire, as we have in cricket, that is Charles Burnston. So I request him to stay on, because he'll be the final say if there is a controversy. So with this, we start the discussion. I'll start the case. This is a story of a 46-year-old female. This is a true case. This lady was admitted Right. This patient was admitted just 2 months back. She didn't have any previous illness. She presented to us with 2.5 months history of diarrhea, blood in stools. She has lost weight and she was anorectic. She had tachycardia and low-grade fever. Abdomen was soft. On nutritional assessment, she had features suggestive of nutritional deficiencies, and the BMI and the mid-arm circumference were on the lower side, and the hand grip was also weak, indicating that she had evidence of malnourishment, and she was sarcopenic. The flex sigmoido showed the vascular pattern was lost. There was some bleeding in the lumen, and she had ulcers. So based on this, her UCEAS score was 6 and Mayo score was 3. We can see a few exudates looking like pseudomembranes. Her biopsy was consistent with a diagnosis of ulcerative colitis. Her hemoglobin was low, platelets were high, RFTs were normal. Significantly, albumin was very low, and CRP quantitative and fecal calprotectin both were quite high. So what gave a bit twist was that her stool for GDH and C. diff toxin was positive. It was positive for the GDH and for both A and B toxin. So we have a patient who falls into severe ulcerative colitis by True-Love and Witz criteria. The number of stools was more than 6. She had blood in stools. CRP was high. She had tachycardia. So she was put on intravenous fluids, injectable hydrocortisone, vancomycin because C. diff was positive, low molecular weight heparin, and antal nutrition. So with this, we start our discussion. And my first question is for Chris, that how common is C. diff infection at first presentation of ulcerative colitis? And how do you manage such patients? Meaning that will the treatment of IBD differ in a person who's got concomitant C. diff infection? Dr. Chris, please.
Yeah, very nice to join you. It's very interesting. To be honest, I discussed it with a few colleagues from other universities as well. As a matter of fact, we never saw a patient who is presenting with C. diff at the first exacerbation of ulcerative colitis. And in general, C. diff in our population is very low compared with, for instance, I suppose Canada or the United States. But of course, we are familiar with C. diff induced or coexistent infection during exacerbation of ulcerative colitis. We see it rarely, let's say only once a year. Then the main topic is how to treat those patients. In general, what we have learned from a fecal donation, as you are one of the leaders in the field in ulcerative colitis, is that you have a better result if you treat them with a combo of induction treatment for ulcerative colitis to bring down the inflammation, because if the inflammation is lower, and there's more and more literature about it, then the eradication of C. diff is also better. So in general, we do start with those patients also with hydrocortisone and Vanco. And then the problem is, and there's now a new European guideline in workup, so to say, if you are in our part of the world, in Europe, industry is forcing us almost to use more and more fidaxomicin. In general, I think the approach of Vanco is good enough. And in case you have a Vanco failure or a relapse, we would give a fecal donation.
Thank you. So in this patient, because this lady had acute severe ulcerative colitis, and my only reservation is to use FMT in such a patient because she has very severe disease. But you're right, we start with the steroids. Steroids is a reasonable choice in such patients. The question is about the use of immunomodulators and biologics. The data is very limited, but there's no absolute contraindication for these medicines, and these can be considered after a careful risk-benefit evaluation and clinical judgment. So this patient was given hydrocortisone, and what we saw by day 5, her stool frequency was still high, and her CRP was also high. She didn't have fever, tachycardia settled down, but stool frequency did not settle down. I would like to ask Nijat that what will be his approach in a patient like this who's not responded to IV hydrocortisone for 5 days. And we please keep it in mind that COVID is around. So I mean, bit of that discussion also in this case. So Dr. Nijat.
Well, actually, it's obvious that we are facing with acute severe colitis. So from the first day of the admission of the patient, I prefer to prepare the preliminary event to evaluate the patient for starting the therapy with anti-TNF and especially Infliximab. So from the first while I focus on stabilization of the patient, I request for viral serology, especially hepatitis B and hepatitis C, and quantiferon for latent TB. And then in the day 3 or 5, if there was not a complete response, I starting anti-TNF for the patient, and simultaneously we can adding an immunomodulator to with the management of the patient. But if anti-TNF was not available in the center, because if you're working in a developing world, it sometimes happens, then you should keep in mind that you have also another option. For example, intravenous cyclosporine could be a very good rescue therapy for stabilization of the patient, that you can use intravenous form of cyclosporine for 5 consecutive days with a dose of 2 to 4 milligrams per kilograms of weight. And also simultaneously, I think that it's better that you consult with a experienced surgeon in your center, that he or she be available, that presence of such cases. And in case of no response, even emergent surgery could be an option for stabilization of the patient.
Thank you. I agree with you. And we also have the same policy. I mean, in such a situation, we offer them Infliximab and cyclosporine. In fact, we have reported our experience with both the drugs. Somehow, of late, the cyclosporine use has become less common. Maybe it's an orphan drug. and we use more often of Infliximab nowadays. But in this lady, if we go through the number of medicines available, I mean, you're right that we can offer her cyclosporin or biologics, and among the biologics, Infliximab is likely to be most effective. We have other choices. Now, we offered her Infliximab. The cost was a factor, and she said that she can't afford Infliximab. She had low serum cholesterol and she had C. diff positive. We were not very sure about the safety of cyclosporin in presence of C. diff, and it has limited availability. She was not willing for surgery. So after having a long discussion with her, we discussed that there is another drug which doesn't have much database at the moment, but which can be thought of, and that's an oral drug. And she agreed, and we put her on Tophascitnib in a higher dose. That means 10 milligram 3 times a day. We thought we'll give a higher dose for 7 days and then come back to twice a day. So at this stage, I would like to ask Devendra that what are his comments on use of Tophascitnib in admitted indoor severe ulcerative colitis patients. Dr. Devendra, please.
Good evening and thank you. This is a very interesting question at these times. So let us first talk about acute severe ulcerative colitis. And we know that the data in acute severe ulcerative colitis is from the case series. And I could find 3 case series with 10 patients where Tophascitnib was used, and it was used in 30 milligram per day, and it was quite useful. Now, let us come to moderate to severe ulcerative colitis, and there has been the analysis from the moderate to severe and severe cases, and it is useful. The efficacy is about 29%. So I would like to take a balanced view that yes, it is useful in limited experience. I would also like to have the other side. What is the total efficacy of Tophascitnib in moderate to severe ulcerative colitis? It is about 29%. Also, looking at the experience of 4,900 patients in rheumatoid arthritis who have a long follow-up, 52% of the patients actually discontinued the drug. So, taking a balanced view, yes, in this patient, it was appropriate decision, and in such situation, one could use Tophascitnib. Thank you.
Thank you, Devendra.
Can I make a remark?
Yes.
Maybe you have to mention what is the cost of Tophascitnib in India, because we're jealous for your price.
The 10 milligram tablet costs half a US dollar.
Okay, fantastic.
Thank you. So just to share the data with you on use of Tophascitnib in acute severe ulcerative colitis, as Devendra has mentioned, that there are few case reports and very small case series. And we have 2 case series report of 4 cases each. And they did mention that Tophascitnib works in acute severe ulcerative colitis. And this data is from Get Hit cohort, where Tophascitnib was used as a rescue therapy in patients who have initially failed with biologics, Infliximab or cyclosporin. And there also they found that the clinical response was good, more than 60%, and so much so even clinical remission was achieved in 45% and 35% patients at week 6 and week 14. There were adverse events, as Charles has been mentioning. The Tophascitnib has its own problems, herpes specifically, and elderly people in this series also, more than 60 patients had herpes. But thankfully, the venous thromboembolic episodes were not seen. I would just like to make one comment here that we learn from dermatology when it comes to use of biologics. And most of the times, the adverse events, they run in parallel. But there is a possibility that some of the events may differ in different diseases. So that is why it's important that we generate our own data on use of these drugs in IBD. Now, Tophascitnib has been used in combination with Infliximab, and there is a case report of 5 patients where a combo of Infliximab and Tophascitnib did work. So these are very small data, but this is the initial phase. We are still in the learning phase. So that's why the limited data is available. Now, what happened to this patient that by day 4, the stool frequency thankfully decreased and CRP also decreased. But what happened that she had another event? She developed fever with chills and she had UTI. Her culture was positive. She had ESBL. And so we were in a fix whether this UTI infection is because of Tophascitnib or it happened de novo. We put her on carbapenems. And at this stage, I would like to invite Dr. Matthew, my friend. Is Matthew there? I haven't seen him.
Are you able to see
Yes,
him?
yes. Right. So would you like to comment on that? How to use antibiotics in patients with active infection, like she had UTI and history of recent C. diff infection? And what are the common infections you think that can happen with Tophascitnib? Would you like to consider UTI also as a side effect of Tophascitnib here?
Yes. Now, thank you, Ajit, for asking me this question. And it's a very tricky situation. There are two aspects of this. This patient has a Clostridium difficile infection. We need to treat them with antibiotic and how to choose antibiotic for them. Another situation is a patient who had a recent C. difficile infection or maybe having an active infection at present now because it's only a couple of days now. So how to choose antibiotics in that? But one thing is that we have to see that in patients with the C. difficile, the severity of infection decides on what is the dose and what's the type of antibiotic used for C. difficile. So in a patient with a mild to moderate disease, we can, in India, many times we use metronidazole, but most commonly used or safe drug or effective drug is vancomycin. So in mild to moderate disease with the C. difficile in patient setting of ulcerative colitis, you need to use vancomycin 125 milligram orally 4 times daily for 10 to 14 days. And in severe disease, you need to use it again, vancomycin 125 milligram only. But in patients with the complicated disease, as we get in severe acute ulcerative colitis, who is in ICU setting, you need to use a higher dose of vancomycin, that is 500 milligram, either by mouth or by nasogastric tube 4 times daily. Or in that, if the patient is sensitive to that, or any patient is not tolerating, then you can use metronidazole or a combination of metronidazole and vancomycin. That is the situation where we use. When you get a recurrent C. difficile infection, we can use again vancomycin with the first instance, or what you use is you can switch over to other drug, like if the patient has got a second recurrence, then we have to use the fidaxomicin, or in patient get subsequent recurrence. That means you have.
Sorry, Matthew, sorry. I mean, you answered this. Would you like to refer to the second point also, that do you feel that UTI is related to Tophascitnib?
Yeah, I'm coming to it. So after once you treat C. difficile, and in this patient who has got an active infection due to other systemic infection, we know that Tophascitnib can produce systemic infection, and as Professor Burnston has told, that we can have other infections as well. So in this context, if I am using an antibiotic, carbapenem, I will definitely add on a patient preventive aspect for C. difficile also. And in this particular patient has got a UTI. We know that usage of Tophascitnib can help produce serious infections. And besides, the commonest concern many people, some studies have shown, that is herpes zoster infections. And I feel that probably Tophascitnib would have contributed a UTI for this particular patient.
Right, thank you. Just to share
what do you think? UTI?
No, I agree. I agree with you, Matthew. Now, just to share with you the information on use of antibiotics, I mean, the few small series. In one series, they use parenteral aminoglycosides, where patient had C. diff and infection, and the other series reported use of tigecycline, which has action against C. diff also, in combination with vancomycin and metrogyl. So this is the review article that sleeping with the enemy, if C. diff infection is there in ICU setup, the antibiotics which can be considered safer are ticoplanin, tigecycline, rifaximin, and serotomycin. But some of these antibiotics mentioned here are not available in our country. So if need be, one has to use, but use very carefully. Now coming to the risk of infections, like we've been mentioning about UTI, about the risk of infection with TOFA. This is a study from Colitis clinical program. And as Charles mentioned, that serious infections do occur more common with during induction phase and with the higher dose. And but if you look at it, serious infections are there, but not very frequent. During maintenance phase, the infection rate is less. Herpes and non-herpes, both opportunistic infection risk remains, so we need to be very cautious. Now, looking at the literature, UTI has been mentioned as one of the infections which can come up in patients who are on tophascitnib. So this makes us more alert that we have to be watchful for infections in any patient who goes on tophascitnib. Now, we can't forget COVID-19 pandemic. This question is for all the panelists and Charles also, that will you use tophascitnib in today's time when the pandemic is still there, in a situation like this, in a severe ulcerative colitis, indoor patients where the indication is equivocal? I think we can start with Chris, then we can.
Well, our population at the moment, 84% is vaccinated. So I would presume that such a patient of 46 years of age in our country, of middle class, upper class, would have accepted the vaccine already. So I would give it. Otherwise, I would give it also to the other patients in general, because I think the isolation in our units during hospitalization is quite good against the risk for COVID.
Thank you. Thank you. Nijat, what is your opinion?
Yes, actually the data is controversial, but I think that there is no contraindication for prescribing tophascitnib, but you should mention the patient who going definitive vaccination against COVID, and also be persuade the social isolation and using personal hygiene and face masks. And in this way, like any other immunosuppressant medication, you can also prescribe tophascitnib, no problem.
Thank you. Devendra? Is Devendra there? Matthew, can you take up this question?
Yeah. I will be more comfortable to use anti-TNFs because we know that we have enough data and we are more comfortable. The experience is there. But tophascitnib is a new drug, and our experience with that drug is not much. And in COVID-19 pandemic, I would put it as a second or third option. But I would definitely consider anti-TNF. But there maybe there may not be much problem with using tophascitnib. But my kind of feeling is that I would put it as a second or third line.
Thank you. Now, I'll request Charles to take up this question if he is still there.
Yeah, can you guys hear me?
Yes, right.
I'll answer this question and then I have a comment about your case. So in terms of this question, I actually like what Matthew just said. I think that we have to be circumspect, and we don't really know about tophascitnib during the pandemic. There's some data in the secure registry that's available. I would be very mindful of age and comorbidity, and we know that age and comorbidity, especially cardiovascular comorbidity, are risk factors for COVID-19. They're risk factors for other adverse effects in tophascitnib. So I would really be limiting my tophascitnib use currently to younger people. What is younger? That's a moving target. The older I get, the younger everybody else gets, it seems. But I don't know whether, for instance, under 50 is really the cut point where I'd be really looking to use other drugs rather than tofa, especially during the COVID-19 pandemic, because of the risks for tofa in older people, especially over 60, and also for the pandemic. We don't really know what the antibody response will be in any of these drugs, biologics or otherwise, But as Matthew was alluding to, we seem to know that in the secure registry, people on anti-TNFs didn't do worse if they got COVID.
Yeah.
So I agree that TOFA should be a second or third line agent during the pandemic. One comment I wanted to make, Ajit, if I have a minute, in your case, one of the confounding issues with your case, and we certainly seem to have more C. diff here than perhaps Chris is seeing in Holland, but I'm actually managing 2 cases right now that have UC and C. diff. But you presented a case of a new presentation of UC, and so we only know that it was UC kind of retrospectively. If we see that patient in the emergency room with acute severe colitis who's C. diff positive, I actually wouldn't have started steroids. I would have assumed that they were having a very bad C. diff infection and would have treated them for C. diff and not assumed that it was UC as well until time evolved and they weren't getting better once I had their C. diff treated. So that's one of the difficulties if they've never been diagnosed with UC before. One way you can help decide for yourself whether this might be C. diff or might be UC, if you scope the patient, and as in other UC patients, there's a relatively abrupt cutoff between active disease and normal, that would make me think this is more UC going on than necessarily the C. diff, which shouldn't have an abrupt cutoff. So just a couple of points about that first case.
Yes, agree. Totally agree.
Dr. Sood, I'd like to just ask a question, is that one is during the pandemic and then the vaccination strategies. I think we also need to understand that with the Clarity study now showing that with Infliximab, antibody response is much poorer compared to vedolizumab, and perhaps Vido should be used for that reason, maybe preferred within the biologics. How do we place Tophascitnib in that group? I mean, maybe Charles or Professor Sood, if you could.
Yes, I'm going to refer to this point also. Just next
No,
slide.
next slide,
Matthew, I'll come to this point. Right. Thank you, Rupert. I agree with the Charles' concern. This patient was 46 years and she was vaccinated. She didn't have any comorbid conditions. So we did discuss, in fact, this question did come up for discussion whether it's only C. diff or whether it's UC. And subsequently, when she was better, she still had changes of colitis.
No, but I have another question. We were talking about the thrombosis item in TOFA, but we have to realize that all acute ulcerative colitis exacerbation patients have an elevated risk for thrombosis. So my question to you, Ajit, is did you take preventive, did you do any prophylaxis for thrombosis in this very sick patient?
Yes, she was on low molecular weight heparin from the initial phase, because that was as a part of protocol for treating acute severe ulcerative colitis. Now coming to the impact of various IBD drugs on 2 points. One, acquiring SARS coronavirus 2 infection, and number 2, about the severity of disease. Now, the various drugs which have been studied include anti-integrins, anti-TNF agents, JAK inhibitors, and steroids. This data is from Veterans Affairs Healthcare System, and what they reported that the risk of SARS coronavirus 2 is more in patients who are on steroids and who are on vedolizumab, while the risk of having a severe disease is more with patients on steroids as compared to Tophascitnib. So that's a bit assuring. Now, this is about the outcome of IBD patients who've been on various IBD drugs, including Tophascitnib, and this comparison was in relation to the hospitalization rates, ICU admissions, requirement of ventilators, and death rate. Now, if you look at the data, the patients on TOFA did not do worse compared to the other medicines for IBD. So these two studies are a bit reassuring that the concern is there, but the Tophascitnib doesn't behave much worse as compared to other drugs. So this is the last question, and I'll start with Chris again. that we know that we've been discussing anti-TNF agents, anti-integrins, and JAK inhibitors. Now, in a patient with acute severe ulcerative colitis, now what is this? Where will he position Tophascitnib in the positioning of this Tophascitnib in relation to other drugs? I mean, that is the theme of the panel discussion today.
Okay, so in general, in very severe acute steroid refractory patients, there's still the choice between Cyclo and Infliximab. Infliximab in the Netherlands, the industry is now saying Cyclo has never been registered for this, so you behave very dangerous. But okay, I see that the majority of younger gastroenterologists move now to Infliximab. In an acute exacerbation, in general, we never use Tophascitnib. We use Infliximab or Humira or the biosimilars, of course. And as second choice, but not in the acute, we switch to the Fado for these sort of patients on the longer run if there's refractory. And the third choice in general, if they are waiting for surgery, we start Tophascitnib. The numbers of Tofa in our country are still very low, I would say. Otherwise, I think that the drug will do much better in the near future. And I would vaccinate them in general already in an early stage with Shingrix, the varicella zoster vaccine. The interesting thing is we're all talking about the American vaccine, and the idea is that they are better than the others. But okay, so
can I involve Rupa also in this? Rupa, will you agree when I say that Tofa is becoming popular drug in India? You have a huge data of IBD patients.
I completely agree, and I think see what happens here, and I think Dr. Sood and all panelists from this part of the world will agree. Sometimes we have the cost issue, and if that is it, there will soon be a time when patient will say, why not start Tofa first, and if it doesn't work, then we will think beyond. So
Thank you.
think
the good thing is that your price is so low compared. Let's say less than $1 a day for a full dosage is extremely attractive, and we have to pay 10-fold, 20-fold. I would say 30 times more than you are.
Maybe
Right.
Charles can also add to this,
Yeah,
because
I-
that is
I-
the Western versus this perspective.
I know Charles' mind. I know what is his answer. So I'll put the question to him in the end. Can I go to Nijab?
As in my clinical practice, my first choice is Infliximab or even adalimumab. And if it was anyway, based on the insurance coverage, then cyclosporin could be a second choice. And I prefer to putting Tophascitnib as the last choice.
Right. Thank you. And Vendra?
Infliximab, cyclosporin, and Tofa.
Thank you. Matthew also agrees?
Same, Infliximab, cyclosporin, and
Okay.
Tophascitnib, because
I know Charles will also the same. Can I request Charles to intervene now? Charles, given a situation, everybody says first choice is Infliximab. Is Charles there? I don't see him.
Yeah, no, I'm here. Can you hear me?
Right. We put a patient on Infliximab and the response is not optimal. Will you consider Tofa as an add-on therapy at that point of time? Say by day 3 or 4, the CRP is still high, the response is not adequate. Will you consider giving a combo?
Yeah, it makes me nervous, I got to admit. I wish I had rapid Infliximab level testing, because if the Infliximab levels were low, very low, I wouldn't be as nervous. But if we've got somebody on high-dose steroids, and we've given them Infliximab, and it's going to circulate for several weeks, and now we're going to add in Tophascitnib, we're really immunocompromising that patient. So I will, when I use Infliximab in acute severe colitis, I use it a little bit more aggressively I give 10 per kilo, and I give it at 0 and 1 week. I don't wait because we don't have that much time. I realize there's really no data to support that, but I do that anyway. If they've been an Infliximab failure already, I would use cyclosporin and I would bridge them to vedolizumab. And much like Chris, Tophascitnib is, although we've had it around, I think it's very promising as a treatment of acute severe colitis. In my experience in moderately severe colitis, it works fairly quickly. So I think it's got a future in this field, but I'm reluctant to mix and match so much because we're really immunocompromising the patient. And I'm really having a serious conversation. If I've started with Infliximab and it's circulating and the patient's failed, and I would talk about surgery. If they absolutely refuse surgery, then I would talk about either cyclosporin or Tophascitnib. I think Tophascitnib is going to be a reasonable choice. I'm just a little bit reluctant on the limited data we have so far.
Right. Last question to you again. Now, in patients who have herpes, what is your take on reuse of Tofa? After how much time? Or like if they have, most of the patients, they don't have a very severe disease, when will you consider re-challenge or challenge again with Tofa in such patients who recover from herpes?
Well, of course, we certainly wait till all of the active lesions are gone. Hopefully they don't have a post-herpetic neuralgia, but even if they do, one could start the Tophascitnib. We don't, as long as the active lesions are dried up and they're gone, I would restart the Tophascitnib. If somebody has an active herpes infection, and I've discussed this with some of my ID colleagues around the country actually, I would wait 1 year and then I would vaccinate them we use Shingrix, the non-live vaccine here. If somebody is on Tophascitnib and we had to start them quickly and they've never been vaccinated against shingles, I would give them the shingles vaccine even while they're on the Tophascitnib.
Yes, fully agree. I think that is what more and more doctors should do.
Right. Thank you. I think that brings to an end, and it's time. And with that, I would like to thank all the panelists and Rupa, Jayanti, and GN. Thank you very much. Back to Rupa and Ramesh.
Very much, Ajit. I think that was a very well conducted panel discussion. A lot of messages coming through, but I think I quite liked Charles' statements that I'd be nervous if we combine these two. I think that's basically a very guarded statement that he made, but I think it's very, very relevant also.
Dr.
So now
can you screen share, then we can see the...
Yeah. So now I think it's time for the open house Q&A session, and I now request Dr. Jayanti to come in and handle the questions from the chat box as well as other questions that have come in. Rupa, other questions that have come in to you. Over to you, Jayanti, first, and then over to Rupa.
Thank you, Ramesh. You can hear me?
Yes.
Okay, so we have one question not really related to the clinical aspect that we discussed now from Dr. Azam. What is the role of IBD microbiome signature?
I think I also request the panelists, Dr. Desai,
this question is to
join in.
Yeah, this
Dr.
question.
Sood, yeah.
This question is probably directed to Professor Charles, who's got a lot of experience with these JAK inhibitors. What is the role of IBD microbiome signature during the use of JAK1 therapy in IBD? A little unrelated, not clinical oriented, but a scientific question. Microbiome signature during
it is as you say, it is a scientific question. I think the short answer is we really don't know. I think we really don't know the outcome of microbiome signatures really for any of the biologics, and the anti-TNFs have been around for 20 years. One of the current interests of our group is actually looking at firstly epigenetic signatures and then ultimately combining them with microbiome signatures. But there's really no data on any of these other drugs. Ashwin and Krishnan published a paper about microbiome signatures with vedolizumab a few years ago. But I think we don't have enough data. There's not enough to comment on. But I think, this is a rich area for study.
Second question is from me. In India, where we have quite a high prevalence of VZV, would you recommend vaccination or consider screening patients for before starting treatment for any of these JAK inhibitors to the panelists?
I mean, I would say that we're very poor around the world, but we're very poor in Manitoba. We've got population-based data. We published it a couple of years ago in the IBD journal, showing how weak we are at vaccinating the general population against VZV. We vaccinate a little bit better in the IBD population, but not a lot better. And one of the problems is we have a national healthcare system in Canada. Patients are quite used to things being free or covered, and the varicella vaccine has not been covered unless you're over the age of 60 and more recently over the age of 50. And so if you're 40, I think you're still at risk, and any of the drugs that we use put you at risk. So I think optimally, if money wasn't the issue, quite frankly, we would vaccinate all IBD patients, certainly from 50 on, I might even say from 40 on, because when we use immunomodulators, we increase the risk. That would be the optimal situation. I know that that doesn't happen, and at least in Canada, Pfizer has offered a program. As Chris has alluded to, Tophascitnib is much more lucrative for them in Canada, but to get us to use it and to get the patients to use it, they're providing free Shingrix vaccine. So if, Topha's cheap there, you're going to use a lot of it, which is great. I think it's a good drug. If you can, I don't know the cost of the vaccine there, I would vaccinate all your IBD patients over the age of 50 the moment you meet them, because you don't know if they're going to end up needing to be a Topha user.
To Dr. Ajit, I'd just like to know that you think this Topha was more like a salvage therapy in your patient, and how do you follow up these patients?
Per se, I feel that if you look at the pyramid of IBD drugs, Tophascitnib has a scope for moderate to severe disease. Now, if a patient has active disease, what are the options to us for UC? Either steroids or Topha. Now, if we compare between the two, the side effect profile of steroids is not better than Topha. Now, tuberculosis, other infections are equally common or more common with steroids rather than Topha. So, in patients with moderate to severe disease who have active disease, there is a scope. Plus, patients who are failure with biologics, non-responders, is another situation where Topha has a scope, because this is
you continue and then switch them over to say as
a biologic failure.
Yeah, no, not necessarily. Like you attain remission and then
what policy we are following, that we put them on 10 BD, and between 8 to 12 weeks we check their fecal calprotectin. We depend on calprotectin. If a calprotectin is less than 100, that time we reduce it. If a patient's calprotectin is high till 16 weeks, we still continue till 16 weeks. So we wait for calprotectin to come down, then we reduce the dose from 10 twice a day to 5 twice a day.
Dr. Rupa, you have a question?
Yeah, so I think Partha wanted a question before Charles.
Partha can take up the question because Charles has to leave.
Yeah, I had a question that because from the basic level, the JAK-STAT pathway actually acts on several cytokines like interleukin 6, interleukin 21 and 23, which are involved in both ulcerative colitis and Crohn's disease. So why is this JAK-STATs have been studied extensively in ulcerative colitis rather not in Crohn's disease?
No, they have been studied for Crohn's as well.
Yeah, but why more so?
Well, what happened, Partha, is in the Pfizer program with Tophascitnib, the preliminary early data in Crohn's disease did not look promising. So they stopped their Crohn's program. I think they're quite sorry that they did. They stopped their Crohn's program and they just kept the UC program. But now, as Rupa's alluding to, especially with the Upasitnib, you're going to see both Crohn's and UC. It was effective in Crohn's disease. So, I think that was sort of an unfortunate choice of Pfizer's to stop the TOFA program. There is another JAK inhibitor in rheumatoid arthritis that we're not going to see in IBD called Berasinib. They do use it, but they still use more UPA and more TOFA than any of the others. I'm not sure if we're really going to see filgotinib in the IBD world, but the next one up is UPA for sure, and it's going to be in both diseases. You're absolutely right.
One last
So
question.
a lot of questions are coming in.
Dr. Charles, one last question from DN Ramesh. Is there any way to assess the quantify the risk of BZV in patients being put on TOFA? Any way of assessing?
Yeah. In terms of actually quantifying the risk by measuring serology in some way is not useful. I put up a slide that talks about risk factors. Age is the key risk factor. The older we get, the more likely we are to be susceptible to having an expression of shingles. And that's why, the vaccines were for over 60, then over 50. And in my view, people over 40, if we're going to give them immunosuppressives, we're going to increase the risk. If they're smokers, there seems to be an increased risk. And you folks seem to have a higher risk than we do in the West. I don't know why that is, but that just seems to be the case, and that was borne out in some of those rheumatoid arthritis studies. So that's a long answer. The short answer is, other than age and the use of other immunosuppressives, there really isn't anything a good marker.
So I have a question. I think this has come from Dr. Anant Gupta, and this is a question we would like to ask the Western world. We'd ask Iran, and of course, panelists from India. It's a little bit of a challenging question. So he says that for corticosteroids, the latest papers are showing that you don't need aminosalicylates together with the mesalamines, together with the corticosteroids when you're treating severe colitis. So the question is, can Tophascitnib be used alone? Or should it always be combined with 5-ASA? Because when you're talking of cost perspective, that is the second part of the question from Dr. Anant Gupta, the price of Tophascitnib is almost half that of the high-end 5-ASA. So is this a rational point to change to TOFA alone?
I don't think you need to use any biologic or TOFA with the 5-ASA. I think once they're well on their drug, whether it's Infliximab, quite frankly, even Imuran, or whether it's TOFA, you can stop the 5-ASA. I think it's a waste of money.
Well, Charles, I think you need to leave. So I will thank you very much for joining, and it was really a big pleasure from the entire IBDENC team and all our panelists to have you on the show. We'll of course continue with the open house question.
Okay, thanks, Rupa. It was a pleasure to be with you all. I wish we could be there in person.
Thank you very much.
And it's great to see you, Chris. You're looking good.
Okay, and all the best to all friends in India. We hope COVID will be over.
Chris, we need you. We still have questions for you.
Oh, for me. Okay, go on.
Say, Ruba, I have a question. It's a very simple question. This has been asked to me by different people. See, in a patient with a C. difficile ulcerative colitis, the same question here what Ajis was asked me. Patient has got a UTI. So you want to combine an antibiotic and probably treat C. difficile also. So how do you do that? Should we change out to teicoplanin, or you have to give the conventional antibiotic for whichever is sensitive for the patient for the infection, and then continue with vancomycin? I want opinion from others also.
I think Chris and Dr. Sood.
Yes. Okay, first let Chris take up.
Okay. It's again a good question, but the problem is we would be if we don't see improvement on Vanco, we will especially in an urinary infection, we will take the slurry and give the patient a fecal donation, and then discuss the antibiotics again.
Yes, now this lady had UTI and we went according to the sensitivity. It was the ESBL was sensitive to carbapenems, and we used that, and she did respond. But we need to keep it in mind that if given a choice, if teicoplanin is an option or tigecycline is an option, then those drugs can be little preferred, knowing that they are little safer. But very, very limited data is there on these issues.
No, the question is that your patient also had C. difficile infection. So were you treating with the vancomycin in that patient along with this one?
Yes, right from beginning.
Yeah. So you have a combination of carbapenems plus vancomycin.
Yes,
I want to make a remark about this. As fidaxomicin is moving forward at the moment in Europe, some doctors would switch in case of a urinary infection directly to fidaxomicin and give the proper antibiotics separately in the same patient, also already for the urinary infection. So combining fidaxo with the other antibiotics.
How Clostridium difficile do you see in Iran? Because I'm just talking about the Middle East concept. Because in India, they are seeing in the West. In India, we see, or do we not check?
Sorry?
I
can hear.
Yeah.
Rupa, your voice is breaking. We couldn't hear the question.
So what was the question? In Iran?
The question is that in Clostridium difficile infection, I think in the Western world, it is being reported much more than what we are seeing in India. So I was asking that what is the story like in Iran? Do you see a lot of Clostridium difficile?
Yes.
And in India,
nowadays.
Yes, please.
Yeah. Nowadays, Clostridium difficile is quite popular here, and very frequently we're facing with Clostridium difficile, and it's really important to think about Clostridium difficile infection. And usually we don't waste time while we're sending the stool sample for toxin aside. We are starting oral vancomycin, which is very fantastic results. And about urinary tract infection, if you have a combination of the Clostridium difficile infection and UTI, you can use oral medicine like fluoroquinolone, such as levofloxacin could be a good choice with combination with oral vancomycin, or even rifaximin could be a good choice.
So what do you think in India, are we testing less or?
No, I think Ruba, let me tell about mine. I am routinely doing for all ulcerative colitis patient for a first presentation, especially for severe ulcerative colitis patient. I do C. difficile. It's not that rare. We are seeing more and more C. difficile now because we are doing more of C. difficile. So I think we should be doing for all patients who comes with an acute exacerbation of ulcerative colitis, and probably you'll pick up more of C. difficile.
I totally agree that this infection is definitely becoming more common, more because we are now looking more often. Earlier on, we were not so particular about C. diff and CMV. Both infections are fairly common. I would say not rare at all.
CMV also we are picking up more.
CMV is also becoming more common since the time we started doing IHC regularly in the biopsy. Our pickup rate has gone up, so we treat many more patients nowadays.
I want to make a remark about C. diff at the moment in the Netherlands. The C. diff in the hospitals since the COVID outbreak is going down with more than 80–90%. And this means that so-called washing your hands and behaving proper with hygiene has a lot of good results against C. diff as well. So what we have learned is that we probably in the past didn't behave good enough in our hospitals for C. diff, and now thanks to COVID we do better. It sounds strange, but this is reality.
Yeah, if I can just add one problem here, that we are using alcohol-based sterilizers, and alcohol doesn't kill the spores of C. diff. We need to use soap and water.
We are forbidden.
We are so used to use now alcohol-based
in the units.
This is a very interesting thing, and I think for everyone to, and for even for clinical practice, when we talk, I think this is a very important point that you said, because everyone is using alcohol-based sanitizer. I can see Dr. Ramesh now. Dr. Ramesh.
Yeah, Rupa,
Yeah,
can I just say, Rupa is going to come up with the information. You sent us a performa based on questioning about the C. diff infection. I think you would have collected data on C. diff infection in India, in the country, isn't it?
I think we have just done on acute severe ulcerative colitis and how many people have access to C. diff testing. And surprisingly, it is very low across the ENC region.
Right.
I think we'll share the data with the entire group.
Dr.
Ramesh.
Yes, I think we have run out of time. A lot of messages which have come out, but I think the most important thing has been said at the end, that is CMV and C. diff. These are the two infections that we need to be wary about. We've been told that the incidence of C. diff has come down, but still I think here we need to be wary about this particular problem, especially when you're going to use a molecule like Tophascitnib. So thanks a lot, Ajit, and to the panelists. I think it was lovely, very basic, clinically relevant panel discussion, and I think all of us have got a lot to take home with this panel discussion. So as is the trend, every IBD ENC meeting, we have one country being represented, gastroenterology or IBD in that particular country being represented. And today it is Kuwait, the turn of Kuwait. And over to Rupa for introducing Dr. Omar, and also for the video, which is 4 minutes long, I was told.
I think, yes, we are just going to show you the message from Kuwait. Professor Mahmoud Omar from Kuwait, professor in gastroenterology at the leading hospital and university at Kuwait, is a strong pillar for the IBD ENC, and here is what he has to say. Can I have the video, please?
Good afternoon, everybody. I'd like to thank Dr. Rupa for inviting me for this webinar. I'd like also to extend my sincere thanks to Dr. Nagiridi for his support, not only for our group, but also for me personally. Before going to IBD, this is the map of Kuwait. Kuwait is a small country of about 18,000 kilometers, located at the western part of Asia, at the Arabian Gulf, surrounded by Iraq from the north and then by Saudi Arabia from other parts. Population of Kuwait is around 4.7 millions, 1.5 million of Kuwaiti nationals, and the rest of about 3.2 million are expats, mainly Indians and Egyptians. For a long time, since the 17th century, Kuwait was considered the main port of trade with India, but now, as you know, it is one of the main oil-producing countries. Going back to IBD, before the 80s, IBD was rare or not existing. In 1983, the first study that mentioned ulcerative colitis and found that ulcerative colitis was the most common pathology detected in colonoscopy was published. 1 year later, another study was considered the first study that mentioned Crohn's disease among Kuwaiti patients. 30 years later, a group from Kuwait University published an article about ulcerative colitis based on Montreal classification. As you can see from this table, there is equal numbers between males and females. This table related to the age at the diagnosis, and you can see 3 peaks. The main peak, 26 to year-old group, and then two small peaks, one for adolescent 11 to 15 years old, and the other one 51 to 55. The same group from Kuwait University published another article about Crohn's disease, where 206 Arab patients living in Kuwait were included. 86% were Kuwaiti, and the others were Arabs, mainly Egyptians, Syrians, and Lebanese. Again, as you can see here, there is no difference between males and females. What is new here is the family history. About 20% of the included patient had the family history of Crohn's disease. Main symptoms of the disease were abdominal pain, diarrhea, and weight loss. This table from the same study compared the numbers of Kuwait with the other published studies from Saudi Arabia, Lebanon, Israel, China, Europe, and USA. The two main points I'd like to mention here is the location of the disease, mainly ileum in 56% of the patients in Kuwait, and the behavior is mainly non-stricturing, non-penetrating in about 70% of the included patients. In general, IBD is equally common in males and females. Patients with presents more commonly at younger age. Crohn's disease is limited to the ileum. Extensive ulcer colitis is associated with younger age at diagnosis and absence of tobacco smoking. Thank you very much.
Thank you, Professor Omar. And I think with this, we come to an end. I'd hand it over to Dr. Jayanti.
Thank you, Rupa. You would like to mention about the forthcoming program before I propose?
Yes, so we have the last two slides.
Yeah, you can show that and then.
So our next program is on endoscopy in IBD, and this is 17th of September 2021. And all of you who are listening, please block and mark your date. And as I said, nothing is complete. I must thank our academic partners for the masterclass and IBDENC, Janssen, Dr. Reddy Labs, Micro Labs, and Takeda. So thank you from Team AIG at IBDENC.
So before we conclude today's session, I propose a vote of thanks on behalf of our course director, Dr. Rupa Banerjee, and my co-chair, Dr. Ramesh, GN Ramesh, and we thank profusely Professor Charles Burnston for a wonderful coverage on small molecules in IBD, focusing on both JAK1 and JAK3, followed by a wonderful panel discussion, which was really a practice-oriented discussion, spearheaded by Dr. Ajit Sood, with an elite panelists comprising of Professor Charles, Professor Nejad, Dr. Matthew Phillip, and Dr. Devendra Desai. And we also thank Professor Omar for giving us a wonderful coverage on the IBD problems as currently faced by them in Kuwait. Thank you all for your participation, and good night to all. Bye.
Thank you. Thank you, everybody.
Thank you, Jayanti. Thank you all.
Thank you. Thank you. Bye. Yeah.
Thank you. Thank you. Thank you, everyone. Dr. Pejman, thank you for joining from Iran. Chris, heartfelt thanks. And I hope soon we will have a big IBDENC meeting in person, when all of us from all across the region can be a part. Dr. Sood, thank you so much. It was an excellent case and discussion. I think we had a lot of practical tips which will be useful.